Yeah.
Hello.
Hello.
It is so nice to meet you. Oh, sorry, say that again. I didn't catch it.
Nice to meet you as well.
Oh, okay, perfect. Hello. I've met you before. You probably don't remember, but a couple years ago you did like a pelvic floor presentation thing at a chiropractic office in I think it was Highland or something like that.
How about in kids or kids for chiropractic or kids only? No.
I honestly don't even remember. I just heard pelvic floor therapist and I was like, I'm there. And so I
Yeah.
showed up and you were there and you gave a presentation. And then I like watched your YouTube video after. And then ever since then, I've been promoting your clinic
Amazing.
because I was
Yeah.
like, this is someone I can trust. Instead of just sending to like any pelvic floor therapist, which I'm sure they're all great, I was like, okay, at least I like have heard from this woman. She really knows what she's talking about.
Well, thank you so much.
Yes. Oh, but I am excited to officially meet you. I'm Nikki.
Yes, Betty.
Okay, so I am just already recording, so I'm just gonna do the intro first and then dive right in if that's all right with you.
Sounds great.
Perfect. All right, everyone, and hello and welcome back to the LDS Sexologist. Today we have an amazing guest with us. This is Dr. Betty, a pelvic floor therapist and founder of Reborn Pelvic Health and Wellness in Utah. She has more than 13 years of experience, and she's helped thousands of women navigate pregnancy, postpartum recovery, pelvic pain, leaking, painful sex, and so many other issues that are often brushed off as just a part of having kids or just being a woman. So she is here today to answer some of my clients' top questions and my own when it comes to pelvic health and especially pain during sex. So thank you so much for being here today, Dr. Betty.
You're welcome. Thank you so much for having me.
Okay, we are just going to dive right in because I have constant questions that come in because of who I work with. I work with women that typically struggle with sexual dysfunction, and a lot of times that presents itself as pain during sex. So I often refer my clients to pelvic floor therapists, and you are one of my top ones that I do refer to in Utah because you have had I've had so many of my clients come back and tell me how incredible it was, and we're able to really progress with them in their sex education and also the sex therapy side as well. Because once we can eliminate that pain, then we can actually have something to look forward to. But I wanted to know what are some of the biggest misconceptions that people have about pelvic floor health, especially when it comes to pain during sex?
Yeah, great question. So most people think it's common and normal and that you just have to deal with it and suck it up and it's just the way it is, which is simply not true, right?
Yeah.
Sex should be pleasurable, enjoyable, in a time of connection. And sex can, as we all know, can mean many different things for many different people. And so making sure that it is an enjoyable experience for both partners is really key. And so I think people just don't know what they don't know because they've either heard from friends or that's their own experience, or maybe their mom is like, yeah, this is uncomfortable. And like, I mean, I can remember growing up and being told, like, oh, yeah, the first time you have sex, it's really
Mm.
painful. And like, first time postpartum, it's really painful. Like, and it's just pain, like, and so you hear a lot of that noise, right? And so just knowing that that's simply not true and it doesn't have to be true. So I think that's the biggest misconception.
Yes, I love that because I will ask a lot of questions. I do a lot of speaking events, and one of the number one questions I ask is, it's a trick question. I put it on the board. I'm like, is it normal to have pain even if it's the first time? And then, most of the time they'll submit the answer of yes. And I say, no, we need to stop normalizing pain. Because pain is a great indicator that something's not going quite right, that we need to listen to our bodies more. And especially with the clients that I work with, they so often come with that where they've been told it's normal. And so then they don't get help, but then it only increases because they're trying to push through the pain and then their nervous system freaks out and it just becomes a huge issue. And it's so heartbreaking to me. So, can you help us understand what exactly is happening in the body during intercourse? So, which pelvic floor muscles are involved in that, and what might be happening if someone is experiencing pain?
Yeah, multi-level questions there. So I'll try and
Yes.
tackle all the pieces. So, during penetrative intercourse, in a female in the vaginal canal. We'll just clarify some definitions there.
Yeah.
Um, all the pelvic floor muscles are involved, right? So they all the pelvic floor muscles wrap around the vaginal canal. The vaginal canal stretches. It is meant to stretch and accommodate whether that's a baby coming out or something going in, all sorts of things. So your vaginal canal actually doesn't feel. There's like no sensations
Mm.
in that. It's made to stretch, right?
Yes.
The pelvic floor, those have nerve endings, right? And so when those things stretch, and those muscles stretch, you might feel that, or you could feel discomfort or things like that, depending on what's going on, right? And so pain can be generated from a bunch of different things. It can be generated from the hymen or the tissue remnants on the outside of the vaginal canal, right? The entrance
Mm.
in. And so that can cause pain or discomfort just from that tissue if it's not usually that comes away. And there's all different variations of hymen. So there could be a hymen that's perforated or not perforated, and that could cause extreme pain. There could be skin sensitivity issues like lichen sclerosis or vestibulodynia and types of things like that, where the tissue itself has generation of pain for a variety of different reasons, whether that's
Mm.
neurogenic or proliferative or other drivers that cause that pain, right? So we almost have to lens out. And I know I'm getting a little clinical on that. And then you have the muscles itself. So if there's any scar tissue from previous birth injuries, if there's any past history of trauma, whether that's sexual trauma, emotional trauma, a fall and a tailbone trauma, right? A birth trauma, right? There's
Yeah.
could be a variety of those things that can cause those muscles to be guarded because, like you mentioned, the nervous system is so integral into this. And so if your nervous system has had a heightened experience that, and there's a great book called Body Keeps the Score. I'm sure you've read it.
Mhm.
And so if there's an insult to your nervous system or a threat to your nervous system that says, ooh, there's a lion here, let me guard, protect, right? And so our body gets in that cycle, that pain cycle of pain, protect, and it just spirals, right? And that's where we come in as physical therapists and occupational therapists, specifically in pelvic health, to be able to say, like, let's break that pain cycle. Let's get your body to realize there's no lion here anymore. Let's get the nervous system to calm down so that the tissue moves the way it should, accommodates the way it should, it supports the way it should, like all the things, right? And
Yeah.
so those muscle pieces there. And so really the muscles are just at the entrance of the pelvic floor during penetrative intercourse. And then you also have your organs too. So like if your organs are and your fascia around your organs are not moving well, or you have endometriosis or adenomyosis or other pain generating things can cause issues during intercourse as well. And so there can be all of these steps along the way from like skin, right? To
Yeah.
muscles, to organs, to hip mechanics, back mechanic, like low back sacrum, all SI stuff, right? All of the joints as well, because if you don't have good hip mobility or ability to move in different positions, or like let's take for example someone who's had maybe a hip replacement, maybe they can't get their leg in a position that they normally would, so they might have to figure out different positioning or work on mobility to helping it open that up for a possibility, right? So there's many different points along the way that can create discomfort during intercourse. I don't know if I hit everything on that question, but follow up
Y-
with more if
Yes,
I.
you did. I do have follow-ups for you. Okay, two just off the top of my head. First being, oh my goodness, when you are, with someone and they're saying, "Oh, I have pain during sex," my guess is you're like, let's figure out where that's coming from. And that must be quite the process because I'm sure some women are listening to this going like, "Oh my goodness, it could be from anything."
Yeah, yeah. Well, think it simply like this. I don't want to overwhelm people. Think of it as a
Mhm.
check engine light on your car, right? There's a check engine light on your car. I have zero clue what's going on, nor do I care. I just want someone to fix it and make it better, right? And
Mhm.
so I take my car to the mechanic. They do the diagnostic thing, right? They figure out what's going on. Oh, you need X, Y, Z. Okay, great, fix it, right? And
Yeah.
like I don't that's not my job to figure out, right? And the same thing for us. It's not you as the patient figuring out like, oh my gosh, where is this coming from? That's our job. Like
Right.
we know we can figure that out. We have the diagnostics to do it. We have the special tests, we have the assessments, we have the evaluation, we have all of the things to be like, okay, these are the drivers of what this pain is. This is how we're going to develop a treatment plan so that you can get from pain with sex to no pain with sex, and we will take you through that step by step to get there. And you don't have to worry about that. That's our job. That's what we take care of for you.
Oh my goodness, I love that. And we will be going over kind of what that diagnostic test looks like, what that would entail. But we're gonna get to that. But my immediate second question that you mentioned lichen sclerosis, and I feel like a lot of women don't know what that is, even though it can be quite prevalent, much more than women realize. So can you tell us a little bit about what that is? Because that might be a term people are unfamiliar with.
Yeah, I'll keep it really high level. I don't want to get too far in the weeds for your listeners, but
Yeah.
it's a skin condition, dermatological condition where like the tissue is really sensitive and it has sensitivities to different changes and things that are going on and stimuli in there, and it can cause a little bit more of like discomfort, right? And so that's a collaborative treatment approach with like whether that's an OB-GYN or a gynecologist or us, and like multifactorial in that to make sure that we're addressing all the areas that we can collaboratively. It's not a one-stop shop with a PT on that. It's a very collaborative approach. Same thing would be with like interstitial cystitis or
Mm,
painful bladder syndrome, or if there's like prolapse as well. Like
mm,
there's a lot where like we can do a lot in our silo as physical therapists and occupational therapists, but our lens is very much musculoskeletal, neuromuscular, all of the things like that, and then ability to screen as well to bring in other collaborative medical providers that can do those sorts of scopes of practice. And the same thing would go with like
mm.
postpartum or menopause, perimenopause, where your estrogen is down and maybe you just need topical estrogen. And that's the reason you have pain with intercourse. You know what I mean? Because the tissue just isn't
Right.
as supple as it usually does when there's a high estrogen content to be like, oh, and now it feels okay. And so we often have to collaborate with other medical providers when it's not physical, right? And
Hmm.
then musculoskeletal, neuromuscular component. And so that's really where we specialize in is that piece. And then we refer out and team up with others that can help with like, we can't prescribe estrogen cream. We can't prescribe or do surgeries. We can't like, there's other pieces that there our skill set and our scope only goes so far, and we need to overlap with a lot of other providers to really give quality care to the patients.
Oh, I love that. And I love hearing how aware you are, of course, you have to be in your field of all the other different things and how they may work together. And do you find, this is just, a question for you, that do you find that that doesn't always translate the other way around? For instance, here's what I mean is I have many clients that experience pain during sex and they'll go to their gynecologist, right? And I've had some real horror stories, not to say that gynecologists aren't great, because there's a lot of great gynecologists out there. I don't want to, make it seem like there's not. But there seems to be a real lack in referral to a pelvic floor therapist with a lot of these clients that I'm with. And I'm saying, no, no, no. I mean, yes, you can go to the gynecologist, but what you really need is you need a pelvic floor therapist. And I've had them be prescribed. I had a client one time who was prescribed Valium and was told to crush it up and put it vaginally to help with pain, or steroid numbing creams, a lot of things that feel very Band-Aid fix, or I had one client that was given a syringe, just like a water syringe that you would use or like for medicine, very, very thick, very large, has a point on the end, and was told to just, oh, here, take this home, use it as a dilator.
Mhm.
And of course, it was extremely painful for my client, and it was very large. She could barely put in, the smallest size tampon, and so this thing was like 4 times as big, and the structure on it had these sharp ridges, and I was just so baffled of, how are these referrals not getting sent to where they should be going, which to me this is clearly a pelvic floor issue. And pelvic floor therapists, you guys are just like the unsung heroes, in my opinion, of the like sexology world. But do you find that there's a disconnect sometimes between gynecology, people going to a gynecologist when really they should be coming to you or doing it in combination?
Totally. There's so many things I want to touch on with this.
Oh,
So,
please, yeah.
first of all, sometimes the like Valium and the lubes or different things like that can be an important part of the overall treatment plan, depending on
Hmm.
what's going on. Dilators also could be a part of that. However, the
Absolutely.
barbaric dilators that I've heard and seen, especially in Utah, that are given by gynecologists, I'm like, oh my gosh, I'm terrified because we've had the same patients that come to us too. They're like, yeah, this is what I was given. And we're like mortified, right?
Yes.
There are these nice, wonderful dilators that are pretty colors. They're soft, they're
Mhm.
bendable, they graduate up in size. Like we
Yes.
we have the right tools for that. And
Hmm.
so that's one piece of it. The other piece is I think a lot of things are the pendulum shifting, right? So like a lot of the older practicing physicians, not all, but a good chunk of them are like, I don't know what pelvic floor therapy is going to do for you. Just do 100 Kegels a day and
Mm,
it fix it. Or, use this dilator or do that. Like they're not their scope is so narrow that they
mm,
haven't kept up with the rest of everything that's happening in their own field and what their own guidelines are in their own field. And that pelvic floor therapy is grade A evidence, like first line treatment for a ton of these things, right?
Yes.
So, a lot of the newer physicians that are out, I feel like I'm kind of in that like in between of generations, right? Of like
Mm,
everyone older than me is very much like stuck in their ways to a degree. There's a few caveats there,
of
right?
course.
And then most people that are my age or younger, especially the new ones coming out, any new like residency trained, fellowship trained gynecologist, OBGYN, like the moment they know that I'm a pelvic floor therapist or anyone's a pelvic floor therapist, they're like, oh my gosh, I need to have your information. I need to send all my patients to you. Like it's like this huge wide shift, which is incredible,
Right.
incredible. So thankful for that. But they've been educated and trained on the value of like this is what's provided. They're updated on the new guidelines. They're staying up in practice, and they firsthand have seen the benefits for our patients together, right? Same thing with midwives. They're very pro pelvic therapy. They're very like so the more crunchier you get, the more pelvic floor friendly you get. But
Yeah.
there's a big, huge change happening just in general. There's an awareness from the consumer, right? The patient themselves. They're like, hey, like they're coming to you, they might be coming to you, me, anyone, and being like, hey, I heard about pelvic floor therapy. It's like a dinner table conversation now. It's not like, oh no, we don't talk about that. Like,
Right. Right.
people are like, wait, where did you go to pelvic floor therapy? What did they do? Can you tell me more? Like people are leaning into the conversation. And so that's also shifting a lot of that momentum too, because now patients are going to their providers, regardless of what provider that is, whether it's an OB, a gyne, a chiropractor, a sex therapist, a mental health therapist, like an acupuncturist, list a million other people. And they're saying, hey, who should I have on my team? And oftentimes pelvic floor therapy is at that conversation, or they're bringing to their provider like, hey, I think can I get a referral to pelvic floor therapy? And they're like,
Mm,
yeah, no problem. Or, there's still some of that out there where they're like, what do you need that for? You don't need that. Or like, what are they going to do for you? And it's like, those are
right.
the ones that crush you. And you're like, no, no.
Yes.
So I think the solve to that is just continue conversations like this, doing a
Mhm.
podcast like this, spreads awareness. That's our number one biggest area and lever we can pull is just having conversations of like, did you know that pelvic floor therapy is an option? Because that person might not have even known that existed. And that's still our biggest battle, right? Like you and I, we both know how wonderful and great pelvic floor therapists are,
Hmm.
but the average Joe doesn't yet. But it's becoming more and more common, which is a huge, huge positive win.
Oh, I love to see progress being made, especially with women's health and
Mhm.
the amount of people that have been working in these fields for so long, and it feels like they've been like screaming out into the void, being like, there is help, there is, pain isn't normal, there's things that we can do, and I feel like finally that is being heard, and it really gives me a lot of hope. And yeah, when I first found out about pelvic floor therapy, I was the same way. I was like, what's this now? Like, I've never heard of this. I thought it was just you go to your, gynecologist or your OB and like that's it. That's all that's I have that's accessible. And this entire field, in another life, I always say I would be a pelvic floor therapist, but
Love
I decided to go the sex education route.
it's all tied together.
It's all tied together.
I have one more comment to add on to that
Yeah.
question. What we're noticing too is because of the rise of advocacy from the consumer itself, so like patient
Mm,
themselves, and advocating for themselves and asking for things. A lot of all of us, right, are like get to the right provider at the right time for the right care. So like it does no
mm,
one any good to go to a gynecologist if they need to go to a pelvic floor therapist. And same thing, like if they come to us and they need like we don't want to see someone who has a broken bone, like you need to go get that ticket, right? So like we should
yeah.
all have a screening protocol in place to know like, does this belong in my office today, right now? And should I be treating this? And how do we educate patients so that they're going to the right provider first? Because even, for example, like an endometriosis surgeon, like a lot of people who have chronic pelvic pain are trying to get in and see, but maybe they're not a candidate for surgery, or that's not even their driver for pain. So those conversations that we have with our referral partners is like, yeah, they're telling us, they're like, we want you to see them first. And then if you're stuck or you're not getting
Mm,
where they need to go, then send them to us because oftentimes they're going to send them to us anyway because they're not going to operate on something that can also be taken care of or maybe even mitigated and not not need surgery on something, right? Not saying that you don't ever want surgery because there's always a time and place for that, and we advocate for
Right.
patients too when it's appropriate. But we want to make sure that everyone has informed consent along that entire journey, right? Of like, well, here are your options. And I think that's the biggest
Mm.
piece is like, we need everyone to give all of the options so that the patient can then decide what's best for me. Because some patients, it might be therapy, might be the route, and they don't ever want to do surgery. And that's their choice, right? Some patients, they might do a little bit of therapy and decide, yep, I got as far as I can. I'm glad I did it. Now I'm prepped and my surgery is going to be a better outcome because of it. And then I'm going to do therapy on the other side. Or they come in and they're like, okay, I see how much what this is going to do. There's a certain gain that I'm going to make. It's not quite enough of what I want. I'm just going to go, maybe a couple sessions of therapy and go to do surgery and then do this after. So there's multiple situations. So I think the best opportunity we can give all patients in any scenario is like, here are all of your options. Here's what each of those means. Here's the pros and cons. Here's the, success rates, that, this, that, the other thing. And then now you get to make an informed choice for your own body. What do you want? And that can change, right? You can decide one thing and then you're like, never mind, I'm going to go this other way. And so just leaving that open to decision-making processes for the patient themselves is important.
Oh, I could not agree more. As an educator, that's so much of what I do is it's shaped and formed or informed around this idea of informed consent.
Mhm.
That I am here to help you understand what is available and on a very small level, because obviously going to you, they're going to be able to get a much bigger picture of what pelvic floor
Yeah.
therapy can be. But I'm, for a lot of them, like the first introduction of that being an option and helping ease some anxieties that they might have to go see a pelvic floor therapist to even see if that is something that could be helpful to them. But I believe so much in the empowerment of people and allowing them to make a choice because so often if you are struggling with pain or just in anything in like the sex worlds, anything around human sexuality, it seems to be so hidden and allowing it to be this open conversation so that it really can be a choice and it can be consented to and they're not just willing but wanting to get help from certain providers. I feel like it's just so powerful for their healing where they feel like they know what is available. Um, okay, we're gonna jump into my next question, which has to do with a lot of my clients. They struggle with what is called G triple P D, previously known as vaginismus. Well, it's actually two terms combined, but we'll leave it at that because that's what most people know it as. But it's genital pelvic pain penetration disorder. Can you explain a little bit about what that diagnosis means in your context of being a pelvic floor therapist and what is happening with the pelvic floor muscles and the nervous system with someone that presents with G-triple-PD?
Yeah. I'm probably going to be a oddball in like how I answer this question because I'm
Okay.
a little bit biased in this, but hang with me. So I like to think like, okay, say we get a patient coming in, that's their diagnosis, that's what they're saying. My immediate gut reaction is like, we'll see about that. I don't know.
Right.
Because a
That's
lot
the
of
sign
people,
to me of a great, great pelvic floor therapist or great, physician in
yeah,
general. When people come to me and they're like, I have just really low libido. And I'm like, oh, is that right? Yeah, we're
yeah,
gonna
more about
see.
that.
We're gonna
Yeah.
see about that.
Yeah, yeah. So that's my like bias going in, right? So a lot of times, like someone, I'm just going to use the term vaginismus as
Mhm.
as a term instead of the G.
Yeah, yeah.
Yeah, like I'm just going
It's
to use it.
easier. Yes.
It's easier. Yep. So there's like in my clinical lens, there's a actual vaginismus where like the tissue is tight, the muscle's tight, the canal didn't actually form to be as mobile as it should be, right?
Mhm.
And then I would say there's a functional vaginismus where like, okay, it's tight, doesn't move well, but is it actually this? Most likely not. It's more functional. So let me lens out on that a little bit. So true vaginismus of like, okay, tissue doesn't move, the hymen is restricted, the canal is actually smaller. We need to do like structure dilator like work through,
Mhm.
right? And plus the nervous system piece of like down regulation and all the things, right? And is there any trauma that needs to be unpacked and shared in a clinical responsibility with a sex therapist and a mental health therapist and all the other pieces that go with that? And then that can all overlap over here too, right? Like think of
Mhm.
Venn diagram where they overlap. There can be some of that,
Yes.
right? And then we have the functional vaginismus. This is probably more of what we actually see in clinical practice. This still exists. I'm not saying that, but
Yeah,
like
yeah.
tons of this, right? So someone's coming in, pain with sex, can't get a tampon in, can't have penetrative intercourse, XYZ, whatever that is. We're looking at them as a whole system. And actually, their adductors, their inner thighs are really tight and their low back's really tight. And so we ask them to do a Kegel and they can't, it doesn't move because it's so tight. Or we ask them to relax, doesn't move, it's so tight. There's pain, so
Mhm.
tight, no movement. Well, the pelvic floor is just actually trapped in the system. And your low back and your adductors, or maybe even your calves or your jaw, like somewhere along that fascial line, is actually more tight. And that's causing the pelvic floor to be tight in the middle. And it can't move because all this other stuff is tight. So we actually work on all this other stuff. And all of a sudden, without touching the pelvic floor, all of a sudden they can Kegel, and all of a sudden they can reverse Kegel, and all of a sudden they don't have pain with sex. And we didn't even do anything with their pelvic floor because it was trapped in the middle. So that's one scenario, right? There could
Wow.
be also in that same bucket, it could be that their pelvic floor muscles have that trauma and we just need to work down and down regulate and trigger point release or dry needling or manual therapy techniques that mobilization with movement and just get the dilators and all of our other therapy tools in the toolbox to get all of that moving like it should, coordinated like it should, not having pain like it should, and all the things so that it's what it needs to be. So primarily we operate a lot in this bucket, right? Of like a
Mhm.
functional vaginismus where it's like, this is totally treatable, totally doing, and your pelvic floor is just the victim in the middle and it's trapped and we just need to get everything around it happy and help and like moving. So
Yeah.
yeah.
Oh, that is so hope driven. If you were to go to a pelvic floor therapist thinking it's going to be the one where the tissue and everything's really tight and it's like, "Oh, well no, let's just loosen some things up here. Let's just kind of reprogram everything so it can be untrapped in the middle." I love that description. Okay. Now, for women that are saying, okay, I think that this might be something that's helpful for me. I would like to know whether my vaginismus, maybe they have been diagnosed, is coming from a functional place or if it is coming from the more traditional, the first one that you were talking about, that requires a little bit more teamwork with, a sex therapist and things as well. And, uh, oh, sorry, I just lost my train of thought. Okay, those women who are wanting to come in to see if this is going to be helpful for them. A lot of my clients, I always refer them and say, I think that this would be helpful, but they have a lot of anxiety going in where they're afraid of what that could entail and, how much exposure they're going to have of their body. Are people going to be putting fingers up? How many? Like there's a lot of anxiety around that. And when something is so painful as penetration, the thought that it's going to require some sort of penetration can kind of stop them in their tracks. So
Mhm.
can you help take us through what a pelvic floor appointment would look like from someone stepping into your clinic? And let's go with they have a diagnosis of G-triple-PD, so you're going to figure out whether or not that actually is, vaginismus, which version of it. What can they expect and how? The next question, so I'll just preemptively, the next one is going to be, how can they best communicate with you during that appointment to advocate for themselves, to help you be aware of where they're at anxiety level wise, so that you two can have a very collaborative experience. So, but starting with, what can they expect?
Yeah, great question. So, expecting coming in to see us, and I'll speak from our lens, right?
Yeah.
You're going to fill out a bunch of paperwork ahead of time, right? We want to collect as much information so that when we meet with you, we have that information as a therapist to understand and put things together subjectively of like what's going on, what's driving it, what symptoms are you having, where are you at, so you can already have an opportunity to express some of those concerns or that you're uneasy, or if you don't want an internal exam and you want to bypass that for now, like that is always an option. We never force anyone to do any of that. It's all consent driven. Consent is ever evolving. So even if you've consented right now, 2 seconds from now, you can change your mind. And we don't, have to, right? And we can
Mm.
stop or we can do whatever. So we are trauma informed. We are healthcare providers. We see this all day, every day. So this is nothing new for us, right? Just like a dentist, like they look in mouths all the time. Like they do, that is what they do. We work or in and around the pelvis all day long. So you're not alone. You're not the first person. You won't be the last person that has any anxiety around this, trepidation, curiosity. Is this what's going to happen? All the things like we
Yeah.
walk you through the whole thing. So do the paperwork, come in, meet your therapist. It's a lovely human being. We only hire lovely human beings. And then you go back in the private treatment room. You are always welcome to have a chaperone in the room, a medical chaperone. You're welcome to bring other people with you if you'd like your partner to come or someone else. Um, Always optional, and you get to drive that as the patient. And then we do, obviously, it would be then patient driven of like, some people come in and they're like, I'm here to get an internal exam. Okay, great. So we will make sure we do that today. Some people are
Mhm.
like, I don't want that today. Or they're like, I don't know if that's the first thing or the second thing that we need to do. And based on the clinical presentation and the subjective and what we're questioning and asking will drive some of our clinical decision making of like, is this important today? Is it not important today? When is it important to do? What's the patient's cover level? So we're taking into account all of those things, right? So generally speaking, we would start everything external first. We are physical therapists or occupational therapists, we're orthopedic therapists, and we're pelvic therapists. We're like the nerdiest nerds of nerds. And we arrived at the pelvis because that's like the missing piece, but we still look at the whole human, right? So we
Mm.
want to see how you squat. We want to see how you move. We want to see how you go all different directions and balance on one leg. We want to move your body in your hips and your low back. We want to assess your back. We want to assess your breathing. We want to look at your core. We're looking at head to toe, all the things, right? Because that information is also important because it could be a driver of what's happening for the pelvis as well. So we're looking outside the pelvis, around the pelvis, inside the pelvis, all of the things. And then obviously if it's appropriate and consent is provided, we would do an internal exam, whether that's a vaginal exam, a rectal exam, variety of such. We would determine that and educate along the way. Again, all of that informed consent we just talked about. Like we're going to say, okay, this is what this is what it looks like. We would have our handy dandy pelvis and we would walk through like this is what the internal exam will be like. It's similar to an OB or a midwife exam in the sense that it's an internal exam. It's different because we don't have stirrups and we don't have speculums, and
Mm.
we walk you through step by step. And a lot of times we get a lot of wonderful compliments from our patients of like, I felt very informed. I felt like they walked me through every step. Like I was always felt like I was in control. They were so kind and took it at my pace, like all of the things. So we are going to be respectful of all that on our end, right?
Of course.
So for the internal exam, once we do all the external things, internal exam, well, a lot of it's just like, okay, we're going to just observe, right? And that might just be it.
Mm.
We might just visually observe, can you relax? Can you contract? What happens when you do a breath? What happens when you cough? What happens? And that might be it. That might be all we do. If a patient is comfortable and we continue down the path, then we might be like, okay, now we're gonna do an external exam. And so we will maybe palpate or walk down the internal thigh. And so we'll communicate that of like, I'm going to touch your inner thigh now. Are you okay with that? And so we're
Mm.
almost like getting consent every step of the way, if that
Yeah.
makes sense. Okay, I'm touching your inner thigh. Are you okay? Good. I'm going to keep working my way down. Are you good with that? Yep. Okay. I'm going to touch your pubic bone next. You good? Yep. Okay. So it's like this
Mm.
constant evolution of consent throughout. And then we would palpate around externally, doing the same thing. Then we would, change gloves and do an internal exam, obviously asking consent like it's like it'd almost be
Yes.
repetitive. It's like annoyingly repetitive on a podcast, but in clinic, it's like so comes out so naturally for us,
Of
right?
course. Yeah.
And so we would do the internal exam, which we would, from a patient's perspective, I like to say, like, and we have the models, right? And we'll show them on the model first so that they
Mm.
understand what we're going to do. And then they say, yes, okay. And then we walk through that. Internal exam wise, you have 3 layers to your pelvic floor. And
Mm.
so the first layer is about 1 knuckle depth, second layer is about 2 knuckles, third layer is about the third knuckle so that we're able to get in and feel all the muscles around, right? And so we need to be able to palpate those to say, okay, is this the pain driver? Is this not the pain driver? How is the tissue quality there? Is there scar tissue? Like we're trying to figure out all those pieces, right? And so we would work our way around again like a clock and then
Mm.
assess with strength, relax, bear down, all sorts of different information that we're trying to gather through that. And that's kind of what the internal exam would be like. We might end up then doing some treatment while we're there. We might do a rectal assessment, depending if there's like tailbone pain or other things, because the rectal assessment, your pelvic floor kind of sits like this. And
Hmm.
so on the vaginal side, you're getting as much as you can, but there's still a whole nother half over here. So there's indication for a rectal exam, then we would educate on that, go through that, all things like that. But those are all possibilities. Again, the patient's driving that. So if someone's like, yeah, no, this is not for me, no problem. No problem. We have so many tools in our toolbox that we can do so many other things. And it's a perfect example too. So like when someone's postpartum, we don't do an internal exam until they've been cleared at 6 weeks from a midwife or an OB in the sense of like from an infection control risk and healing standpoint. So we're already seeing people 2, 4 weeks postpartum up until 6 weeks, and we're not doing any internal during that time. We're doing breath work, we're doing core work, we're doing glute activation, we're doing all external things because
Yeah.
why wait 6 weeks to start doing that stuff when we can get a head start on it? And then when it's appropriate and able to, then we can add the internal part in. And so it's this fluid moving dynamic of like, what do we need to do today? What's the most important part? What information can we get so that we can make progress? Because we can make so much progress without an internal exam. Obviously, like the internal exam is going to give us valuable information of, okay, what's happening here, 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 because there's a bunch of things that would then be like, oh, this now is making more sense within the big picture. But it doesn't mean you can't start chipping away at the onion as a whole, right? Like we can start peeling off
Right.
layers as we go, and then bigger layers come as we collect more information. And again, patient driving that consent and control of like what information is accessible because it might not be appropriate, right? Like it's not appropriate for me to do an internal exam on a 13-year-old girl ever, really, you know?
Yeah.
So that's another example of like we have to, with our skill set, be able to have conversations and drive different things given the information we have access and data we have access to. If all access is available, great. We will work collaboratively and gather as much data as we can in each little access
Mhm.
point that we can. So think of it as that way of like we have the external access, we have a vaginal canal access, we have rectal canal access, we have visceral canal access, which is organ mobility of like, can we assess that? And so all of those touch points bring more information to get a bigger clinical picture that can drive efficiency, plan of care, treatment in the best way possible for the patient. But again, all of that's out the window if the patient doesn't want an internal exam. Like then we have this to work with. Great, we can
Yeah.
still do that, right?
Yeah.
So hopefully that answers that question a little bit.
Yes, it does. I have some follow-ups for you. When you were talking about, let's focus on an internal, because some of my clients, I think they come from a place of where they think that that could be really beneficial. But two things. I want to know from a pelvic floor therapist standpoint, what are you feeling for? Like, what information are you gathering from an internal exam? What are
Yeah.
some thoughts that you'd be having if they're bearing down? And, tell me a little bit about that. And then the second one would be, let's say it is very, very tight. Like putting your finger in is just, it's not happening.
Yeah.
And how do you help her to not only relax, but what does that tell you about her? And are there different techniques to kind of
Yeah.
help open up the vaginal canal with maybe breathing? Or, if she can't even put in a tampon, maybe she's thinking, well, how is someone going to put their finger in? Because I
Yeah.
can't put anything in here.
Valid thoughts and questions. So I might start with the latter one first and then
Yeah.
work backwards. So if we're seeing that like that's not going to happen or that's a complaint on the paperwork that like I can't get a tampon in, that like we're not going to force that. We're going to probably observe and then see what happens. And then if they're okay with like, okay, we're just going to set our finger at the entrance of the vaginal canal. We're just gathering information even just from that, like what's happening to their
Mm,
nervous system, what's happening to their breathing, are they tightening, are they like and that's giving us plenty of information to say this isn't appropriate right now. And so we're not going to do anything more. We
mm,
might train them to be like, okay, I would need you for your homework. Let's
mm,
have you put your finger at your vaginal canal. Can you downregulate? Can you practice breathing? Can you practice relaxing? Can you move your legs? Can you move your hips? Can you have some movement there with your own touch? Do we get a dilator to do that? Do we do some self work there to begin to peel some of those layers off. Um, and then when it's appropriate, then we would have that again ongoing dynamic conversation of consent and like, does it make sense clinically to do this or not? And when is that? That could be session one, that could be session 15.
Yeah.
That all is different for every single person. And it depends on the person's goals too. Like somebody might be like, okay, I know they need to work on this. Like I've had a patient before, they came in, saw them for one session. They were not in a place ready. We didn't force anything. We, got sex therapy on board, mental health therapy. Like they did a year's work outside of PT to just be able to come back to do PT. And it was the right thing for the patient at that time. Absolutely. And so when she came back, she was like, I'm ready to do this. I've done all the work. I feel really ready and prepared. And so we made so much progress then. And like for her, that was a perfect plan of care for her. Like she got information she needed. She knew she wasn't ready yet. She needed to do some other things to then come back and be ready for the things. And we would have, even if she decided to keep coming, we would have still met her where she was at. But
Yeah.
she was able to make that informed choice of like, what do I personally need to be able to do what I want to do and where my goals are. And so there was a beautiful, beautiful outcome with that. So hopefully that answers that like
Yes,
second
yeah.
question. First question of like what to expect during an internal exam. So I'm going to go probably a little bit more like fast through this one.
Hmm.
So externally, we're going to palpate the pubic bone, work around clockwise on the outside, touching all the pelvic floor muscles. Then internally, we would insert just about that first knuckle, just assessing again what's happening nervous system wise, breathing wise, what's happening to the tissue at the finger. Is there any other things going on? And then we might press down, we might press to the side, we might press the other side, and then we're going to clock up and clock out the other side. We'll insert a little bit more, do the same thing. We're assessing tone of muscles. Is there scar tissue? What's the flexibility? So think of it from our lens as a neuromuscular musculoskeletal lens of
Yeah.
what's the range of motion? What's the tone? What's the movement? Is there any prolapse? How's the coordination? Like we're just like we would look at another muscle, right? We're looking
Yeah.
at what's happening mechanically here. And is there any pain generation? Is there weird, does the tissue feel like trigger pointy here? Is there prolapse? Where is the cervix in relationship to the uterus and all the organs? And like, is like are they discoordinated and can't, like you say, do a Kegel and they bear down, or you say do a Kegel and they or bear down and they do a Kegel. And so we're looking at all the different
Mhm.
things of like, okay, what's happening? Third knuckle, same thing. We're palpating all those things, deeper structures of the muscles. So the deeper doesn't necessarily mean like it's just deeper because we have to be able to reach it,
Mhm.
right? It's in a
Yeah.
bowl. And so you have to be able to reach all the places. And just by length of like, I can't reach anything this far. I have to be able to like, okay, what's
Yeah.
actually happening here? We might assess how the mobility of the organs are with that internal hand because you can do it externally, but you can really understand with internal and external together combined can really give a big valuable picture of like, okay, how does this organ truly move? And does it move appropriately? Is there a restriction there? Does it create pain? Like we're gathering all of that information to figure out like, okay, what's not moving to simplify it, what's not moving and needs to get moving, what's not coordinated or understanding how to move in space and how do we get that how do we help this person understand where their body's in space and how to optimize their movement patterns so that everything plays nicely in the band concert and it's not
Mhm.
like some out of tune instrument over here that's creating havoc in the whole thing, right?
Right.
So that's a little bit about that.
Oh, I think that this is just this one section is going to help so many of my clients. Thank you
Right.
so much for going through that with us. Um, Now, a follow-up question that I always get is like, okay, well, how long is this going to take? If they're going from
We get it all the
Uh,
time.
well, I'm sure you do, where it's like, so, yeah, what's the process here? How long until people tend to notice improvement? It's obviously different for everybody.
Yeah.
But what's kind of a normal average
Yeah.
timeline for
So
people?
every therapist is going to say this. It depends, right? Like that's a
Yes.
typical therapist answer. Um, in general, and this is what we tell people just at face value. In general, anywhere between 6 to 8 visits, you're going to start to feel better. Like you're going to notice, like, okay, I'm in the right place. Things are working the way they're supposed to work. I'm making progress. We take people through 4 stages of care. So that first stage, that kind of 1 to 6 visits is like we're kind of figuring it out like together, right? Like we're peeling off those onion layers, we're doing multiple different assessments, we're doing some treatment. Is it getting the response we want? We're test, treat, retesting, and
Mm.
like, okay, yep, okay, we're going the right path. That we're going to keep going this path. Oh, we hit a dead end. That's not the driver. We got to pivot a little bit here. Let's add this piece in, and then we might get over the next hump, right? So 0 to 6 visits is like really figuring out what's happening and enough treatment that we're making progress. And so then patients are
Mhm.
like, oh, I'm feeling better. This is great. And then somewhere between 6 to 14 visits, they're starting to feel real good. Like most people are feeling
Right.
really good. Their symptoms are down. They're doing things they want to be doing. They are like, oh, yeah, I'm feeling great. And this is usually where this is where our medical system fails and says,
Mm.
okay, you're good. You can be done. And also the
Right.
patient feels themselves because like, I feel great. I don't need any more therapy. But it takes 6 to 8 weeks to build true strength changes and resiliency in your body. So we very much advocate for that third phase of building resiliency. And so we might space your visits out more infrequently. Maybe you're coming a little bit more frequently up front to get through those first 2 phases. But then we're like, okay, now go have sex. Now go jump on the trampoline. Now go do this. Now go lift some heavy weights in the gym, report back. And let's make sure we've built resiliency and capacity in your body to
Yeah.
take on the normal day things and the things you want to do and you're still maintaining, right? Because usually in that phase we'll load or stress something like, ooh, my symptoms kind of came back. That's good information. That's actually still progress because one, you couldn't do any of this before. Two,
Right.
your system, and it still needs a little bit of help in that real world scenario because most people, if they ended before that third phase, would go and then go back and jump on the trampoline or they go have something. They're like, PT didn't work. I still have
Yeah.
pain. And it's like, that's not fair. That's not fair to anyone. That's not fair to the patient. That's not fair to the provider. It's not fair to our profession of not
Mm.
taking everyone through those phases to make sure, did we fully build resiliency in your capacity to be able to tolerate these real world things and get you in the spot where you're like, okay, I understand all this. I've done that. I now can do those things. And that's typically phase 4, where we graduate into maintenance of like, then maintenance looks different for everyone. So someone with endometriosis might be a maintenance patient once a month just to make sure that we're staying here and
Yeah.
not sliding back down, right? And so we want to make sure patients are the expert of their own body, that they know how to manage their symptoms, they know when to come back in before it's an emergency or a red flag, and are able to stay healthy and happy. And that's the cool thing about our jobs is like we get to see the whole continuum and we
Mm.
want people to stay over here, right? That we want to stay in the optimal zone of like health and wellness and I'm feeling good, but we're at a fingertips away, phone call, text message to say,
Yeah.
hey, I slipped a little bit. Like, can I get back in for a tune-up? Like, absolutely. We would love nothing other more than to help keep you here, right? So that's our philosophy on care of those 4 phases of treatment and where to expect, generally speaking. 10 to 16 visits is like an average length of plan of care. I think
Yeah.
14 is the national average for physical therapy in general. But with all those nuances and like 6 to 8, you're going to start to feel better,
Yeah.
feel really better, but don't give up yet. Like you might need just like 1 or 2 more visits for that like capacity
The
build. And
resilience.
you're gonna
Yeah.
be like it's gonna pay so much more bigger dividends later than like quitting too early. And that's I think the piece that is hard because we're not a pill, we're not a surgery, we're not a quick fix. It takes work and it takes time and it takes repetition to also build motor patterns because a lot of people have faulty motor patterns and aren't using their glutes properly or their core properly and they're compensating. And so we want to make sure all that foundation is solid and strong so that you don't go end up back at square one.
Yes, everything that you're saying, when I introduce this and I say, you should go to a pelvic floor therapist, a lot of times people are looking for that quick fix,
Yeah.
right? Which, because totally understandable, if you're having pain, yeah, you want to get rid of that as quickly as possible. But helping them understand that it does stink that it has to be a bit of a longer process. And I tend to work with clients that are also working with a sex therapist, but I'm like, look how far you've already come. You have
Mhm.
already been working through this with a therapist. You've already clearly been seeing a lot of improvement because you have to see a certain amount before you can even come see me. And this is just going to add to that. And in building that resilience, I really resonate with that because that's truly what I want for my clients is I want them to go and yes, it takes a bit of a longer process, but ultimately we are building something that is so much greater than what you have had, greater amount of pleasure that you'll have access to, less pain, and being able to have a more fulfilling life in general, but especially a more fulfilling, intimate, sexual life is so powerful and it's so worth the effort that it takes. So thank you so much for touching on that.
Mhm.
Um, just a couple last questions here. How can patients, I kind of had asked this before, but let's circle back to it. How can patients best communicate with you during their appointments if they're feeling uncomfortable because maybe they're the type of person where they're shy or they're a people pleaser, and so when you're asking for consent and you're being so kind and so, they're like, yeah, okay, but they don't know how to quite speak up for themselves if something is uncomfortable or maybe emotionally difficult. What is the best way for them to let you know? Because really, you can't do anything. You're asking the permission.
Yeah.
You're doing all the things that you can. What are things that maybe they can do or strategies of advocating for themselves and speaking up?
Yeah, I think that's an interesting conversation, right? So, yes, we're asking consent. Yes,
Mhm.
they're saying yes, but we're also reading the body language too on that, right? Like if they're saying yes, but their body's saying no, we're gonna like, right, we're trauma informed, we're gonna
Yeah.
respect that, we're gonna hold space for that, and we're gonna question and not necessarily question like, are you sure? Are you sure you're sure you're sure? It's like we're gonna be like, I'm noticing some responses in your body, like it seems like your body's not ready for this, even though you're saying yes. Maybe we should defer this for another time. Or like we want to give optionality in there so that they know there's an option too. Because again, like you said, someone might be a people pleaser, or there might be a trauma in the past where like they never had the option to say anything, or even if they said something didn't mean anything. And so we want to be respectful in that space from that standpoint. So a lot of body language reading for sure. Because if you're saying yes, but your pelvic floor is like, it's like, but there's a mismatch, clearly, you know?
Yeah.
And so we're gonna read that. And then I forgot what the other part was you said on that question.
Or just how they can communicate with you. What's going to be most helpful to you as a pelvic floor therapist, like information from them?
Yeah, I mean, just verbally, they can tell us or in their paperwork ahead of time, like any information that they think would be important to their clinical care and what we may or may not be doing is valuable information for us because we will walk alongside them with that. And if they can't verbally communicate, we're going to read their body language. And then if there is emotional distress of any kind, which we actually see quite often with some of the dry needling stuff that we do it can evoke a emotional response. And so we leave time and space for that. We stop doing it. We take the time, like all the things, right? And so we're just respectful of that because you just don't know what, especially when you're dealing with body tissue, nervous system things, like we could release something and you might have an emotional response from that. And so that happens more often than not in a lot of
Yeah.
sessions, right? And so and people need different amount of time or processing to work through that. And so there's been times where people are like, no, 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 I'm fine. And like clearly they're not. And so we're having other conversations of like, what other support can we get you? Do you need a mental health therapist? Do you need to talk to your doctor? Do you need to like are there medications that we can help with? Like a lot of people in especially in chronic pelvic pain, there's research to support this too. They actually do really well on a low dose SSRI just to bring their nervous system down a ratchet that then they can make progress because if they're up here all the time, we're like beating our heads against a door, right? And
Yeah.
so there's a ton of research on that. So we might have conversations about that. Did you even know this was an option? Can you talk to your provider about that? Is it something you're interested in? Like, we're never going to force someone to do that. And also,
Yeah.
we can't prescribe that anyway, but we know enough in the research, right, that like this can be
Mhm.
a game changer for people. And so I would say, a handful of times I've said that to a patient, just out of like, as a friend, a goodness
Yeah.
provider, right? I'm like, as your friend and a provider, like, I think you should have this conversation. And there might have been some resistance a little bit in the beginning, but then maybe they come around to it. And they come back and they're like, how did you know? Like this changed my life. Like I had no idea. And so like I've never seen it not be beneficial.
Yeah.
So it goes back to that informed choice of like, do you know this? Did you even know this was an option? And then we see this and we see this as a very beneficial piece to the puzzle. And so I think it's those pieces too, right? Like making
Mhm.
sure that you as a patient need to feel safe, one, in general, two, with your provider, and three, in your own body. And you need to make sure like all of those are synchronized together in a healthy way in order to make progress. And so we just meet people where they're at on all of that.
Oh, I love that. Yes, the more information we have, the better we can understand our bodies and give consent to get more help. Um, I have a question about you said, anyone can come, you can have people in the room. So a lot of times my clients, they do like the idea that their spouse can come in with them. Do you ever have where you show the spouse, if you're giving homework of, I want you to massage internally in this way, or maybe put your fingers here, and
Mhm.
is it ever something that you do where you're kind of showing the spouse, of course, with consent, if that's something that they're comfortable with, where maybe having you do it is a little bit uncomfortable, but they are okay with having their spouse be involved?
Yeah,
Is that something that is an
absolutely.
option? And
Absolutely.
would that
Yeah.
be something that they can just ask for? Like, is this possible? See, there we go. Okay, this is what
Yep,
I wanted
yep.
to know.
They can ask. Sometimes we offer too, because like some
Hmm.
like 'cause I would say this comes up more commonly during pregnancy,
Okay.
with like perineal stretching and things like that to prep for birth. So like they're like, can my husband come and like learn how to do this thing? And I'm like, absolutely, bring him on in. We'll show him, we'll teach him. Like we'll take a whole session to like educate and make sure like they'll watch us do it. We'll train them. They'll do it. They'll get feedback from their spouse on the table of like, did that feel like that? Like
What?
we'll do
Yeah,
the
the
whole thing,
same.
you know? Yeah.
Yeah.
We'll make sure that they feel comfortable replicating that outside of the clinic. Obviously, like we'll give them other things like they can do to help too, but they're right, you're doing someone who's an unskilled clinician from a
Mhm.
skilled clinician. So is it going to be the same? No, but is it better than nothing? Yes. And is it a point of bonding and a point of help and a like support and all? Absolutely. And so yeah, we highly encourage that, especially if someone's interested in it. Absolutely. Bring them in. Let's show them because that also gets gets that overall wraparound care and compliance from a patient standpoint of like, okay, we know they're going to be working on this outside of here too, and we can continue to build a very therapeutic alliance together through that.
Oh, yes, I love that. Making them feel like they're not just alone in this, that
Mhm.
it's not just, oh, well, you're broken, and so this is your problem to figure out, but rather this is a team effort, and there are so many people here to help you
Mhm.
just understand how your body works and get it to the place where, everything's feeling good, that it's not necessarily broken. That narrative, that's the other one, like that pain is normal and, oh, we're just broken.
Yeah.
No, both of those things are not true. And
Yes.
it's just more education and more seeing the right people can really help with that. All right, let me read through. I want to ask you one last question to end. Oh, this one. You mentioned dry needling. So someone might perk up at that or might shrink when they
Yeah.
hear that, when they're like, wait, what's this now?
Yeah.
So there's a lot of different options with pelvic floor therapy. You have pelvic floor exercises, manual therapy, dry needling, biofeedback, dilators, breathing techniques, so much.
Yes.
I think a lot of them people are familiar with, but maybe biofeedback therapy and dry needling, they might be unfamiliar with and curious about what that entails. Can you just speak to that and
Totally.
as possible treatment options?
Yeah. So let's start with biofeedback first. So biofeedback is a buzzy term. Let's just
Yes,
say I
it
have
is. Yeah.
a couple opinions on this one. So there is a biofeedback machine. That is all well and good. Remember, our whole pie of the puzzle, there's Kegels, there's biofeedback, there's all these slices, right, that we
Yeah.
can pull out in treatment modality wise. So there is a biofeedback machine that can show you all the things of like pressure and sensation and like all the stuff. So we do have one of those. Now, is that the best option all the time? Usually not.
Right.
But we also have providers that only will refer if we have said machine. So we have said machine to be like, okay, we have it if that's what the patient needs. Again, it's like, we'll see if they
If
actually
they
need
actually
it.
need it. Yeah.
Uh, And some people do. Like,
Yeah.
don't get me wrong, there are appropriate times and places to do biofeedback in the biofeedback sense of a machine.
Mm.
This is also biofeedback. Sitting on a ball is also biofeedback. Sitting on a towel is biofeedback. Having my hand on your back is biofeedback. Like biofeedback is this like general term of like we do biofeedback all day long, all day, every day in multiple different facets. So I'm just kind of detethering those two of like, yes, we do
Yes.
biofeedback, tons of biofeedback. It's just where is my body in space? What is my body doing? Like that is our whole job is to teach you all of those things. And then there's this like biofeedback device that
Right.
sometimes gets used. So that's like that's the differentiation there of what is biofeedback.
No, thank you. And then dry needling, because this
Dry
one is
needling.
actually, at least in what I've read, I just barely finished a book called Floored, um,
Mhm. Yes.
about pelvic floor therapy. And tell us about dry needling, because I feel like we're sleeping on dry needling.
Oh, it's a game changer. It's like a game changer for clinicians. It's life-changing for patients. I'm just gonna
Mhm.
leave it at that as like the headline.
Yeah.
So dry needling, a lot of people think of it as acupuncture. It's not. So acupuncture and dry needling are two different things. Same needle. Acupuncture is Chinese medicine, chi energy, meridian lines, acupuncture points, does wonderful things.
Yeah.
That's about all I know about acupuncture.
Mhm.
Dry needling is sticking same acupuncture needle, only it could be called a dry needle, into a trigger point in a muscle, into a scar tissue, into some sort of musculoskeletal tissue to either create a twitch response, so trigger point, like a knot in your muscle. And so what happens normally is your muscles slide and glide like this. When there's a trigger point, it gets locked down and doesn't move and slide and glide like it should. Physiologically, I'm going to nerd out here a little bit.
Yeah.
It's oxygen drops, blood flow drops, pH drops, and these neuropeptide chemicals sit there and signal to your brain, ow, pain, dull, sharp, stabbing, whatever your brain's perception, tightness could be. We take a dry needle into that trigger point or trigger points and create twitch responses. And so it's a direct interface to the nervous system. And so, like when your knee gets hit for a reflex hammer and it just like
Mhm.
automatically kicks. It's a reflex. So that needle goes in, hits the trigger point, and it goes boom like that. So it's a contraction. That's a reflex. You have no control over it. And so it kind of like feels like your eyelid twitching, and it just
Yeah.
like twitches with some like spicy, sparkly electricity, even though we don't have any electricity, your body's electric. And so
Mm.
it's like that rock pop feeling in your mouth where it's like like
Yeah.
that. Can be startling because it's kind of like you're walking into a haunted house, but you know something's going to jump, you just don't know when. And so it
Yeah.
could be like, so like some people are like, like they're like triggered by that startle reaction as
Mm.
well. And so as soon as that releases, blood flow comes back in, oxygen comes back in, the pH gets restored. All of a sudden, this moves and glides like it should. Immediately, there's less pain, better mobility, better contractility. The muscle works better. A whole host of wonderful things, both locally in the tissue and because it's a reflex going to the spinal cord. And that then travels up your central nervous system to your brain. So there's like all of these layers to the nervous system that happens, and it is instant. It is so wonderful. Some people hate needles, so it might not be a treatment option for them. Again, let's inform consent. Let's tell you all these things first. You can
Yes.
decide, trial it out, see if it helps or not. Most people, once they trial it, they're like, oh my gosh, whoa. I like what just happened? Like, where'd my pain go? It's gone. Like, it's just
Yeah.
so cool. Some people have zero tolerance for it though. Like their nervous
Mm.
system is so revved, one needle poke and they're in tears and all the things are happening. So we have to judge that of like, is this a treatment modality that's appropriate for them or not? And if it is, great, we'll run with it. And then we're going to dose that appropriately. So the first time you do dry needling, we might just do a couple just to see what happens. How does your nervous system tolerate it? What did you think? Did you get any benefit from that? And then we might do a little bit more each session to add in. Some people, we do it and they're like, yeah, this is not for me. Or they have a needle phobia. We're not going to do dry needling if someone has a needle phobia. You know what I
Right.
mean? So there's a little snapshot on what is dry needling.
And my last question, because I know people are going to ask this, where are
Yeah.
you putting the needles? And that's what they're gonna, yes, where are
Anywhere
those
there's
going?
anywhere there's a muscle. So yes, we can put them in the pelvic floor as well. But so like a lot of times we'll needle your low back muscles like your hip flexors, your quadratus lumborum, your glute muscles, your piriformis, your adductors, your inner thigh, maybe your ab muscles, C-section scar, perineal scar, any of the pelvic floor muscles, calf muscles, TMJ muscles, upper trap, like anywhere there's a muscle, we can stick a needle in it.
Oh, wow. I bet that's just life-changing to see someone go from like coming in with pain and then you do a little dry needling and
Like,
everything's different.
I like to joke around. I'm like, we made you a needle junkie in the best of ways.
I love
Like,
that.
can I have more needles, please? Yes.
That is great. This has just been an incredible conversation. Thank you so much for coming today. To leave us, can you just answer, if someone is listening who has been avoiding intimacy because of pain, what do you want them to know?
That you are worthy.
Ah, thank you so, so much. And I want all of my clients to know that Dr. Betty, her team is available at the Reborn Pelvic Health and Wellness in Utah. How many clinics do you have?
We have five, going to be six this fall. Yeah.
Can you
Mm,
say the locations of where those are
yes.
at?
We have North Logan, Layton, Murray, Lehigh, Provo, and then South Jordan is coming this fall.
Oh, that is absolutely incredible. Now, the other question that people are going to ask, which has to do with insurance or HSA,
Mhm.
how can they get referrals from doctors? Can they just come in? Can I refer them?
Yeah.
How do they come see you?
So great question. Lots of answers there. So one, by law, Utah is a direct access state. So there you can go see a physical therapist without a referral from anyone, anytime, any point, any all the things. There's a caveat to that because some insurances require a referral. So the law says you don't need one, but an insurance carrier to pay for it might say you do. So depending on your insurance, we are a hybrid practice, which means we take most major medical insurances, not all, but we do submit all claims out of network to those ones we don't. So a lot of people still get reimbursement through their out of network benefits. You just have to pay cash at time of service. We also have cash options. We also take HSA, FSA, and care credit. So if you need to finance it for 0%, you can use care credit to do that. I actually did that when I got LASIK eye surgery because I was a new grad, had lots of student loan debt, but he wanted my eyes done. And so I did that like 0% payment plan. It worked out wonderful.
Oh,
Um,
great.
so all of the options are available. And then if we are in network with your insurance, we will obviously do all the things that are required with that.
Oh, wonderful. Thank you so, so much. I cannot wait to send this episode to at least 5 or 6 clients that I have right now. So
Awesome.
you have a fabulous rest of your day. And to everyone listening, I hope that you learned something today. And please join us next week on the LDS Sexologist.
Thanks for having me.
Thank you. We'll see you later.